All right, I'm going to get started. So thank you all for coming along to tonight's Transplant Talk Live, Arrow, the Bone Marrow Transplant Foundation's webinar series. These webinars are an opportunity for us to delve deeper into a number of BMT, stem cell and CAR-T related topics, with tonight's webinar focusing on paediatric stem cell transplants and long-term follow-up. I'm Angela, I'm the Patient Liaison Officer with Arrow, and I am joining you today from the traditional lands of the Wadawurrung people in the Geelong region of Victoria. I have with me today our wonderful host, Yvonne Panic-Hudson. She is a clinical nurse practitioner in haematology at the Peter MacCallum Cancer Centre and Royal Melbourne Hospital. And Yvonne is also the co-host of the wonderful and very informative podcast, The Straight and Marrow. Yvonne's one of the directors on the Arrow board, and she is joining us today from the traditional lands of the Wurundjeri people in Naarm, Melbourne. Along with Yvonne, we are very fortunate to welcome the highly accomplished and experienced clinical nurse consultant and BMT coordinator, Sally Anderson, from the Royal Children's Hospital in Melbourne with us tonight. She is our guest panellist, and she's also joining us from the traditional lands of the Wurundjeri people in Naarm, Melbourne. I will shortly hand over to Yvonne, who will be facilitating the Q&A at the end of Sally's presentation. Please, if you do have any questions throughout the night, pop them in the Q&A section. You can also pop any questions in the chat section, but we do monitor this throughout the evening. We just need you to understand that we are unable to answer any questions relating to your own diagnosis or current treatment, and we will do our best to answer the questions as broadly as possible. If anything does come up from tonight's webinar, we do ask you to seek further advice from your treating team. But we thank you for joining us tonight. And without any further ado, I'm going to hand over to Yvonne, and we hope that you enjoy tonight's evening.
Thanks, Ange, and thanks to Arrow for hosting another webinar series for 2025. It's always a great pleasure to move out of the adult realm and move into pediatrics. And there's no one better to present than Sally Anderson, who is a clinical nurse consultant at the Royal Children's Hospital. And as Ange said, has so much experience, but also so much warmth and compassion for the patients and families that she cares for. I've had the pleasure of working with Sally at the Royal Melbourne Hospital. We've known each other a long time, and it's absolutely wonderful to be hosting tonight. I'm looking forward to your questions at the end, and I'd like to welcome Sally to start presenting. Thanks, Sal.
Thank you, Yvonne. Thank you, Angela. And I shall share my screen. Is that right? Can everyone see?
Yes, Sal.
Is that right?
Can't see it yet, Sal.
Oh, is that better?
No.
Oh, I've got to share.
There we go.
There we go.
That's it.
Yep.
I'm sharing. Okay. That was embarrassing. Okay, thank you. Thank you very much for your kind introduction and opportunity to share and recount experience of caring for children and families going through the bone marrow transplant process. Thanks also to the Arrow Foundation and their great service that you provide for patients and families. The feedback from families re your services is only ever amazing. So congratulations and thank you for your service. Firstly, although I work at the Children's Hospital in Melbourne, it's important to note that we have a close collaborative working relationship with other centres in Australia and New Zealand, and also align with some international bone marrow transplant groups. And so when we talk about what we talk about today would be relevant to practice and experience in other centres as well. Transplant in paediatric settings is a very broad topic to cover, and when Angela asked me to talk about that, I thought, well, what am I going to talk about? So I'm hoping for today to cover broadly the process of transplantation in paediatrics, whilst highlighting some respective time points and supportive care issues that we encounter in that process. To begin with, I'd like to share a recent experience which was both touching but also a good reminder of the important work that we do in the bone marrow transplant setting. When there is an unrelated donor, there is often the question asked, can we contact the donor? Of course, the donor identity and where they are from is both private and confidential information at the time of transplant, and we need to respect that. And so in answer, I would always say you can write a letter to forward a card through the Stem Cell Donor Australia, or as it was known, the ABMDR, and they will forward this on to the donor. Back to the story, which follows on from the question. I'm sitting in my office and there's a knock on the door. The door answered. No, the door didn't answer, but I answered the door. There was a young man and his mum. Let's call them Bill and Liz. Bill had his transplant in 2016, and now it's almost 2025. He was 9 years of age at his transplant, and if we do the math, he's now 18 years. More importantly, he had just completed his VCE. Bill and his mum, Liz, had made a pact some years earlier that when he finished his VCE, he would write a letter of thanks to his donor. With that, he handed me a letter, nothing elaborate, just an A4 piece of school paper with some of his words of thanks and appreciation of their gift. He wanted this to be passed on to the donor. Bill was looking great, his mum was overjoyed, and they had reached a milestone and it needed to be celebrated. They were heading off overseas to visit Liz's family. They passed on their thanks, the letter, and Christmas cheer to the team and the consultant. Eternally grateful for the opportunity to get to this milestone and move on to the next chapter. And dutifully, the letter was sent on its merry way or journey to the donor. As time evolves, so to have the donor confidentiality restrictions. So direct contact between donors and patients is possible now if both parties agree and it's more than 2 years post-donation. They can be organised through the Stem Cell Donor Australia. For Will, he was happy to forward the letter and keep it simple. He was a simple guy. So, just to clarify, in the transplant setting, we talk about bone marrow transplants, BMTs, stem cell transplants, SCTs, and hematopoietic stem cell transplants, HSCTs. Like the triplets, they're same. They're all interchangeable, and I'll probably do that throughout my discussion today. So just also to clarify the difference between allografts and autografts. Autografts are where patients will receive their own cells back, and an allograft is where you receive another person's cells, and that's what I'll be focusing on today. So who are our patients, where do they come from, and how can we best care for them? All patients we are dealing with in their formative years, all the patients. Their ages range between 6 weeks and 18 years. So we have many things to consider for each patient and family when addressing their transplant support and care needs. The scope for growth and development must not be forgotten and should be embraced and forefront to the process and our care approach. And with every patient, we have amazing parents who sometimes may also be in their formative years of parenting, unexpectedly dealing with a situation that was not remotely on their parenting schedule. Or they may be parents who have many other children and have lots of experience. Or they may be parents learning to deal with adolescence, a great challenge that is. Or they may be from interstate or regional patients having to relocate from their safe place and environment to a busy city. The list of variations or differences is hugely extensive, as you can appreciate. So how do we optimize care for the vast range of diversity, and how do we equip them in this strange place with a different language? Firstly, patients and families are integral to working this out. Therefore, leaning in with the patient and family-centred approach to care is fundamental. And for this reason, we need to acknowledge and respect how each family unit functions and work with them for a win-win care situation. We once had an adolescent girl, let's say her name was Viv. Viv was from interstate and she was the oldest of 8 children. She was well loved by her siblings and loving and maternal, being the oldest, to her siblings. She was a typical adolescent, on socials all the time, loved to sleep, and was dismissive if it suited her, and was an avid Grey's Anatomy watcher. Always said she was going to be a doctor, but I think she's done nursing. There was, which is probably better, there was not a way her parents and family could come over to be with her during her time in hospital, but she needed her treatment. With her parents, she nominated a family friend or support, who we'll call Maggie, whom she and her parents knew through her church. They all had a mutual respect and trust for each other. Maggie had seen Viv grow up and she had supported the family through the process. The friend was brave, disconnected from her own family and her own social supports. She was prepared to be there for Viv, and she provided amazing support and took the brunt of Viv's moods and flat moments. Her parents came over when they could, spoke by phone regularly. The ward and nurses became her family and friends. She was well supported by the AYA nurse, who always made her feel special, and other allied support such as social work, education, arts, and the like. Viv understood the pressures for her family and her vulnerabilities. She had some input into how it could work, and she is now many years out doing really well, which is great. So this is just a slide that I think is helpful in simply reminding us that transplants are not a quick fix. It provides a good linear guide to the time points in the space of the year where immune recovery is predicted to take place. First, the neutrophils, and then T cells, and then what follows is the B cells, all required for a good immune recovery and successful transplant. So why do we do transplant in the paediatric setting? Got a list there, and in the setting of leukemia, we know that chemotherapy is not necessarily going to be the best treatment. It can make people very toxic, and transplant offers an added power of a robust new immune system with a modality to manage and recognize the abnormal cells and achieve remission. In the setting of immunodeficiencies, there is something missing in the makeup of the immune system. Therefore, it's not functioning properly. Maybe it's getting overexcited or overactive, or it is not functioning at all, and they need a new system. With bone marrow failure, the building blocks of the marrow are not working. There is a risk of infection and bleeding and a higher risk of cancer, therefore needing replacement. So we need to, so that is important. In hemoglobinopathies, we've done a few of those transplants recently, we do them with the aim to improve quality of life by taking away the constant blood transfusion support and potential side effects that are associated with this. in the setting of metabolic disorders, similar to the immune system, they have some missing links or enzymes that can be debilitating, have debilitating effects long term. So the replacement force is needed. This will not repair any of the damage that's been done, but it will halt the declining process. So just some comments in the paediatric setting. The knowledge of cytogenetics and the immune system has been a change agent and very confirming to the understanding of bone marrow transplant or stem cell transplant. And it is very informative for early diagnosis and determining the treatment pathway that is best for the underlying disease. This has helped in pediatrics. There can be more than one child in the family having a transplant, because if there is an underlying inherited disorder, there is the risk of other children having it. So for families coming into the pediatric setting, it may not be the first time that they are cared for by us. And in the pediatrics, and the other thing in pediatrics, which is very exciting, is that there has been some recent innovative research proposals that have been directed to the pediatric area, and this is very exciting and something to watch for and pave the way for more exciting times. So the pre-transplant period for anyone going, for adults and children, is a very busy time. It's a busy time in the setting that they need to undergo a workup. We need to search for a donor. We need to confirm the collection of cells. We need to organise a pre-transplant workup. We need to ensure that they've got a good central venous access, and we need to understand and research their infectious disease history to minimise risk during the transplant. We also need to think about fertility for them, except I can't actually spell fertility, and we would refer them on to the specialists that would discuss that with them in the setting of so that they're aware of what their options are later on in life. And at the same time, we are needing to educate and inform the family about what is going to be happening for them. We need to equip their toolbox so that they're ready for transplant. And finally, we need to bring them into consent to moving forward into the transplant setting. So I thought what I would do is just talk a little bit about donor selection and how we go about that, and some of the issues that we may encounter in the paediatric setting. And one of the reasons why I think this is important is that we take along, to have a transplant, you need a donor, and we take a lot of time talking about who is the right donor and organising to get the best donor, and we need to, so it's important to have a think about that. So firstly, just looking at a sibling donor. So we have the golden rule that there should be no harm to the donor. So that's something that we need to think about all the time when we're addressing the support and needs for a sibling donor. So each sibling has a 1 in 4 chance to be a compatible donor for their sibling. Because in pediatric settings, they are a minor, we always do a bone marrow harvest, which involves a general anaesthetic and an overnight stay in hospital. The collection process, and also very importantly, we need to have an independent paediatrician assess the child to ensure well-being of the donor. Obviously, this is done with the parents, and the parents are going to be consenting on their behalf, but I suppose there needs to get a sense that there's no coercion, and certainly for older children in the adolescent years, it's important that they have a say on whether they want to be a donor or not. And certainly if there was concern or they didn't feel they could be a donor, that's okay as well. We would look and search for a donor elsewhere for this family, for that particular patient. We need to ensure that there's no harm or trauma associated with the decision. For parents who have a child going through transplant and have one of their other children as the donor, they have very mixed feelings about that period of time. They're very happy that the sibling is a potential donor for their child, but then they're concerned and worried about the impact on the child as well. So it's a very described as a very sort of intense responsibility time for a parent. So there's a few extra things that I think we can consider for sibling donors, remembering that there can be more than, I mentioned before, that there can be more than one child in a family that needs a transplant. So I thought I'd just talk about a particular situation we had, which was very significant and good to think about. So what happens if the sibling is compatible for two siblings? How do we go about that, and what do we need to think about? And this recently happened with a family. There were two older girls who had a similar immune disorder, and they both needed a transplant. They had a younger sister who was 2.5 years old, and she was the match to both of them. There were many questions raised. Is it okay to use the donor twice? What is the physical impact for the donor? What is the psychological impact for the donor? How will this impact the well-being of the donor and the family? The family were very supportive and they were very well balanced. The parents trusted and felt well guided into the considered treatment management that their family needed. It was discussed broadly within the team and nationally, and there was a general agreement to use the same donor for both siblings. As there was a significant weight difference, we needed to do 2 harvests on this child. Knowing that the marrow has a quick regenerative process for children, bones are soft and malleable, and they recover very quickly from a bone marrow harvest. Therefore, it was thought that it was reasonable and a good option for this family to have this donor the sibling as a donor for both the children. They had an ethnic background, and so options of searching for other donors was quite limited. But remembering the rule 101, no harm to the donor. The first transplant took place uneventfully. The second transplant was done a period of months after the first, allowing the donor and the recipient to recover well. When she was coming up for the second donation, again, a donor assessment was necessary rather than the parents being responsible and onerous solely for the consent. The donor, who was now 3 years old, proceeded with an infant mental health assessment, which allowed a rigorous assessment and recognition of her developmental and well-being in the setting of her family unit before consent. And this was done by the infant mental health team, and they observed her behaviour and development in the family setting, as I mentioned. What was observed was she was well-loved and resilient. There were secure relationships in the family. There was a healthy adjustment from the first donation, and there was no signs of medical or hospital-related trauma. There was no issue it was decided that there was no issue to disqualify her from being a bone marrow donor a second time round for her other sister. This was reassuring for the family and was also reassuring for the team by supporting their decisions of using this sibling on 2 occasions. The family have moved away now after being here. They're here for more than a year from interstate, and have returned home, and they're getting on with life and school and play, and the 3 children all have healthy immune systems. So it's a really good story to hear. So if we're thinking about a matched unrelated donor, we have to think whether they're local or international. Obviously, if we were to choose, in choosing a donor, if we had the option, we would go with the local donor first. From a timing perspective, it takes less time to organise and it is less cost. International donors take up to about 6 to 8 weeks to organise and secure a time and a date. So if the transplant is critical or time poor to get them to transplant early, the local donor is the preference. This is managed through the Stem Cell Donor Australia, and donors are, like I spoke about with the sibling donor, they're reviewed at an accredited collection bone marrow transplant centre. Some centres prefer to collect peripheral blood stem cells, but in fact the donor can stipulate a bone marrow harvest if that is what they want. Once secured, we would work around the date of collection and arrival of the cells in planning for day 0 and the surrounding transplant. In the setting, if we were using a cord, again, this can be local or international. We need to get the cord. The cord needs to arrive at our centre. We've got a cell lab here. It arrives at the centre, and the quality check the number of cells that are stipulated in the donor source, check the cells and make sure that they're all viable and would be a viable option of donor source for the recipient. This can take a couple of, usually takes 2 weeks. And once this is all done, then we can get a donor clearance. The donor clearance can be done and we can move forward to the transplant. In the setting of using haploidentical, there is also the haploidentical option for our patients. So we can use a parent or a sibling has been used before, but it's not a routine thing that we would do. When we would use a parent and go forward with a haploidentical transplant, it would be if it's difficult to find a donor and the donor option is not timely enough, or in the setting that we would maybe do a second transplant for someone, because if you're having to do a second transplant, we would always change something in the recipe to aim for a successful transplant. So going back to the pre-transplant period, importantly, we need to do our no surprises test, as Dave Ritchie likes to call them, the pre-transplant workup. So looking at organ function, looking at organ function and testing everything from heart, lungs, liver, kidney, doing as I mentioned before, infection disease history is very important. And within the 30 days, doing our infectious disease marker blood sets. We also need to make sure our patients are ready for transplant by assessing their disease burden. In the setting of leukemia, that would be by testing their MRD, and in the immune disorders, making sure that their inflammation or their infections are well under control and not going to cause concerns during the process. For leukemia patients, we usually are doing this pretty much in the month before they come to transplant. For other patients in the cohort from sort of immune or hemoglobinopathies or metabolic disorders, the period of time for doing the pre-transplant workup can be up to years, actually, because they're more as sort of elective transplants. So going back to sort of revisit our pre-transplant period, just to revisit this for a moment and remind us of what we need to do to get to our last little point here, which is our good to go. So we usually have what we call our good to go. It's presenting the patients when they've done all the hard work of getting their disease under control, getting all the information that they need. The family have got themselves organised. From a family perspective, we would have a meeting to present the patient to the broader team, present it to the ward nurses, pharmacy, allied health, and we get them ticked off as ready to go so that everyone knows and understands the process of what got them to the transplant, why we're doing the transplant, any issues that we need to be concerned about the transplant. So this is a really good way of sort of collaboratively presenting the patient to the broader team. And of course, the last thing that we need to tick off is the donor clearance. And this can be very frustrating where we've done everything else and then a donor clearance does not come back the way we want it. We would need to start again. So we're ready to go on our transplant and we need the right recipe to get us in the right state of physical well-being to receive the stem cells. So conditioning treatment usually goes for about 7 to 12 days, depending on the underlying condition and the donor logistics. And the aim of conditioning is to make space for the new cells and to calm the immune system down to allow the donated cells to enter into the body calmly. We use a combination of medications similar to those used in the adult setting. The only thing differently would be that we are doing an age and size dosing rather than the adult dosing. And essentially with conditioning, we're all working towards day 0. So day 0 is always an achievement to get to. It's always a relief for families. It's often an uneventful day, but it's exciting because we can, when we sort of give a family a planner, we start counting down the days from day to get to day 0, and then we can start counting up the days, and that's always a positive sign. a lot of our patients in just going back to the conditioning treatment, a lot of our patients may not have had chemotherapy before. So the chemotherapy part of the process can be overwhelming and quite daunting for them. For patients who have a leukemia diagnosis, they're very used to chemotherapy and very used to that sort of process. So day 0, it's good to get to day 0 because we get to infuse the stem cells. It's a very big day if their sibling is the donor, because as you can imagine, you've got a child in the transplant unit, and then you've got a child that's going to theatre in the morning to have the bone marrow harvest done and staying overnight. So it's a time that I usually say to families, make sure you've got another set of hands on board, just to keep someone in both camps and manage to get a cup of coffee and look after yourself as well. So the next stage of the process, I'm calling day 1 to engraftment, because engraftment is the next stage that people are wanting to get to. But in between there, because of the chemotherapy, it's a period of time where there's risk of infection, there can be mucositis, there can be some organ toxicity. We need to ensure that we've got good pain management. Very importantly, we need to think about nutritional support, because it's at this stage where they're probably not eating, but they've got the new stem cells on board. So we need to ensure that we're providing them with the nutrition to grow a new immune system and get those stem cells working. We need to think and we need to ensure that they're getting the appropriate blood product support during this time. Engraftment day can vary from, an early engraft would be around day 10, maybe if it was a haplotransplant, to sort of day 28 for, a cord transplant or sometimes a sibling transplant. It's going to depend on how many stem cells we've got as well, the quality of the graft. So it's always a good sign and a good time when we start seeing those white cells growing. Engraftment to day 30. So the marrow is recovering. It's very active. The graft is very active, and we're focusing on with our daily assessments. We're focusing on skin, gut, and liver, and kidneys, making sure that they're all working happily and not too unhappy. During this working up to day 30, it's the first time point for donor assessment to see how the transplant is actually working. So we do, in the setting of leukemia patients, we will do a marrow to look for absence of disease in the and we will also do a chimerism for other patients without a leukemic diagnosis. We will just do bloods and do a chimerism test at that point in time. It always usually takes us a couple of weeks to get that result back. So it's a bit of a wait for the families, but it's a good point to be at. Okay, so day 30 to day 60, and I've got day 100 there. I'm moving through the days now. It's a time of, and hopefully by day 100, we're thinking about planning for discharge. But during that time, we've got constant vigilance of organ function, infection, and we're really watching for, this is a time that we start to watch for reactivation of viruses, which can cause some problems there for patients. And it's always a good day when I get to plan discharge. So I like those days. I like those weeks. So we've got a huge allied health support team who work with us, with these families. They're amazing. When I come back in another life, I'm going to be either an art therapist or a music therapist because they have the best jobs. And they do an amazing job. And I would really encourage families to try and engage with these supportive services because they really help to get you through transplant. You can see I've got a few spelling mistakes in that slide too. I need to get my education happening, I think. Comfort First is an amazing service that assists with procedural pain and procedures, which is a very busy service, in the setting of managing central line dressings and things like that. They're amazing. Social work, obviously very important, and dietitians, fundamentally important as well. So just a nice little slide. Music therapy gives children power and well-being. So I always encourage the music therapists and to engage with families. Even if the baby is 6 weeks old, there are still things that can be done with music therapy for these families. Art therapy is great for kids. And the most amazing thing about these services is that on a daily basis, we come around to the patients and we do the doctors will be doing their physical assessments, we'll be looking at the skin, we'll be very medically orientated. Definitely there's some play in there, but, it's the daily contact, and it's always about, feeling their tummies, looking in their mouths, asking about their poos and their wees and everything, so medically orientated. And when you see them working with the art therapists and the music therapists, you just see a different side of them. They're just smiling, they're happy, they're engaging, they're enjoying that sort of moment where they're doing something nice. So it's so important for them. And education is hugely important as well. We do kinder to VCE, and the day that 3-year-old kinder became a service for us was the best day ever, and celebrated hugely by the 3 to 4-year-olds with gusto. They love it. They just can't wait for their kinder teacher to come in the morning, and they sit down and they'll been lying there doing nothing, and then all of a sudden, you go around to do your medical rounds and they don't want to see you, they don't want to talk to you, and then the kinder teacher comes in and they're like sitting up doing things. It's really great to see and so important for them. I know on the opening slide I was we were talking about follow-up as well. So I think I'm really only going to talk about the immediate follow-up post-discharge. In the setting of long-term follow-up, that's almost a separate presentation because it's quite involved and important to know about. So, but just today I'm just going to talk about what would happen when you go to outpatients. So you've gotten through your successful transplant and you've been grafted, and you've managed to move through all the toxicities, and you're eating and drinking. You've got rid of your IV pole with all its supportive medicines, etc. And you're ready for discharge. Yeah, so in that setting, you'll be coming in on usually twice weekly to outpatients, where you'll get reviewed, you get blood counts done, you get your drug levels done, testing your immune drugs, cyclosporin and tacrolimus. You will be getting some blood product support if needed, but hopefully by the time you're discharging, your marrow is starting to work well and you're not really needing too many blood products. You'll be assessed for your nutritional support, and we'll be starting to wean your medications. Stretching, we usually then stretch out to weekly, then second weekly and monthly. we need you to be close to the hospital. For regional patients, we would still like you to be at least, an hour from the hospital during this period of time. Once you're sort of about 6 months, is usually when, or 4 to 6 months, if everything is going well, then we sort of lessen the rope a little bit, and you're probably likely to sort of move home, because and getting back to school is usually when we start thinking about vaccinations, and that could be around about the 6-month mark, depending on how the immune system is going, and depending on the underlying disease. And then transitioning to long-term follow-up after you've been seen for a few years, and if you're all going well. So that's about all as from the process point of view. I just thought I would like to share another little story that I encountered the other day, which was a very nice little experience. So just bear with me for a moment. So to finish off, I was at work the other day, and one of the young doctors sidled up to me and asked me how long I'd worked on the ward for. I immediately thought, well, I'm going to get my hair coloured and my brows done next week. But she mentioned to me that her sister was once a patient under the transplant unit. And I was very touched and a bit hesitant, because it was not, it's 8 o'clock. We shared a conversation. Her sister was now 18 years old, but at the time she was around the age of 1, and she had a leukemia. And I did recognise the name, and I remembered her mum. The young doctor remembered the time well as the older sister and the donor. She remembered the meeting. She remembered the meeting when she met with the doctor to talk about herself being a donor. She always felt very proud to take on the role of a donor, and probably chose her career because of her experience. Her sister is doing really well and is embracing adult life with gusto, and it was a great moment to share with her, and I thanked her for that. And thank you very much, Yvonne and Angela, for asking me. I think that's me.
Thanks, Sally.
Thank you, Sal.
That was incredible. It was so informative, but it was also like a walk through your amazing career as well, with the stories that you shared and all the your great knowledge that that you've shared with the audience tonight. There are some fantastic questions in the chat, but before I ask your question, I'm going to share some feedback from Monique, who says, "You're a superstar, Sal." Thanks, Monique. It's so true. So I'm going to start with, do you need a breather, Sal? Oh, you've had a drink of water. That's good. I'm going to start sort of early on. So there's a question about bone marrow harvests and biopsies, and just asking how they differ. What's the difference between a bone marrow biopsy and a bone marrow harvest?
So bone marrow biopsy is just an investigational test where they pop a little needle in and take out a little bit of bone marrow and test it under the microscope. A bone marrow harvest uses the same access point, but we're taking off bone marrow, which is like liquid. So our iliac bones, our iliac crests, are like a reservoir or a lake of stem cell and blood. And so when they do a harvest, they pop in a needle each side of the hip and draw out the marrow, and then that goes to our cell lab. They process it, and then it comes back and would be infused. So you should get Maddie Gilsnan, who you know very well. She's the bone marrow queen over here at the moment and does all the bone marrow harvest, and she's very, very proud of the number of stem cells she gets. So yes.
That's great.
And the bone marrow aspirate is done regularly because it's a investigational test looking at how healthy the marrow is.
Great, thanks, Sal. There's another question here from Rochelle, who asks, what percentage of paediatric transplants are from cord blood versus stem cells? Now, this is obviously you're going to answer this very differently to if you were an adult transplanter.
So cord blood it's a little bit dependent on where. There are some hospitals that like to use cord blood, and there are some hospitals that have a preference for marrow or HPC. So it really depends. We don't do a lot of cord transplants, but we do them if it's our only option. Obviously, a cord is a finite number of cells, and you only get what you get in the cord that's been donated. So the considerations that we need to think about are the size of the recipient. So whatever number there needs to support the recipient. So it's important to make sure that we've got enough stem cells in that cord that are going to support the growth for that recipient. In saying that, cord cells are a little bit different because they're naive cells. They haven't been exposed to viruses and the like, and so they take longer to engraft as well. So they can sometimes leave you in a sort of at risk of infection and things like that, and for a longer period of time. So I think that's why we're perhaps a little hesitant sometimes to use them. But I know that there are some centres that do a lot of work with with cord blood, and I think they're sort of starting to have a bit of a resurgence in England at the moment. Yeah, I went to a conference and heard someone presenting there. It was quite interesting stuff.
Yeah, that's interesting because we do them infrequently in the adult transplant setting. Partly because we often need to use two cords because adults are bigger, so the cords have to match each other and match the recipient.
Yeah.
And in adult cell, do the pediatric recipients, the kids, stay in hospital a bit longer because engraftment takes a bit longer?
So yes, we're very very protective of our patients. Well, it's hard to manage them. That as children, it's hard to manage their nutrition and things like that. So yeah, so they're usually in for a little bit longer. That I would normally say to someone that they'll be in for about 6 to 8 weeks minimum, and that is if everything goes well.
Yeah.
Yeah.
So I'm just conscious of time.
Yes. Sorry, I didn't.
No, not at all. No. Gosh, we could listen to you all night, Sal. There's a really fabulous question from Cindy. And Cindy says, thank you for all that you do and for the difference you make in families like ours, in our lives every day, Sal. My question is, from your experience, what makes the biggest difference in a child's recovery, medically or emotionally?
Chicken and the egg.
Probably a bit of both, isn't it?
I think very much a bit of both. I think parents are integral there, like having parents who are engaging and willing to are willing. Every parents are different. All parents are different, and parents are parents. They're there for their child, and they're there to support them, and they do it, you know, in a way that the child is used to. So
Yeah.
as long as their parents are there, you know, I think, and you know that. But I think engaging in those other supportive measures can really be helpful and really sort of improve well-being. And you see it once they start to do a few nice things and do a bit of play, and you know they start to sort of come out of their shell and they start to feel better. So I think you need both. I think you can't do one without the other. I think that it's really about yeah, just trying to you know, keep that well-being of everyone that's surrounded, and importantly, and I'd say this, importantly, it's then about parents looking after themselves.
Good.
And that's probably the hard thing for parents. Sometimes they want, for someone who's staying 24/7, 7 days a week, you know, I say to them, you really need to start to look after yourselves, have a break. It's okay to have a break, and you know, you will feel better for it, and you will be able to sort of cope with being in hospital as well, and therefore you're looking after the child in a happier way.
Yeah, absolutely. And I loved your story about the day play in the kindergarten, and you know how you know the kids might run away from the traditional medical team but run towards the people that are running the fabulous programs.
Mm-hmm.
So it was really lovely to hear all of that. Well, on behalf of Ange and I and our wonderful audience and Arrow, the Bone Marrow Transplant Foundation, Sally, I'd like to thank you again for everything you do, and just the comments in the chat demonstrate how appreciated you are. So thank you, and thank you for sharing all of your knowledge tonight. And I'm going to hand over to Ange.
Thank you, Yvonne, and thank you, Sal. It was so good to have you.
Can I just say I forgot to thank the team that I work with, because I don't, you know, I'm just one of many. I can't do what I do, you know, without everybody else. So it's very remiss of me not to actually acknowledge the team that I work with. So every day they surprise me, and they're an amazing crew.
Absolutely. I completely agree. And so I'll say the same. You were such an amazing support to our family when we were going through transplant, and it's so lovely to see you still doing the same role, because I know that every family who is looked after by you will be thinking the same as me. We'll never forget you, and you're an amazing person. And so as is the whole team there at the Children's. I loved that slide you did with all the allied health services, because every single service is just so important. So yeah, absolutely fantastic. So thank you so much for joining us tonight. And to our audience, we really appreciate you coming on board tonight and watching. We value your support, and it's great to have you on board at these webinars. We hope you get a lot out of them, as much as we do, because we love each one. We do have a short survey at the end of this. If you would kindly fill that out when you are leaving, it does help us for future webinars, and it's completely anonymous, but it does help us go further into what we're doing, and just each time we run one, we can do things a little bit better or provide you with what you actually want to hear, which is great. And this is how we get to the subjects that we get to each time. So if you do have any questions, as I said at the start of the webinar, that has anything to do with your own child's diagnosis or your own situation, please do contact your treating healthcare teams. If you do have any questions for us at Arrow, we would love to hear from you. You can contact us via our website. at www.arrow.org.au, and you can also email us at info@arrow.org.au. We're always here to support all our BMT and stem cell and CAR-T patients and their carers. So thank you again for joining. Thanks, Sal. It was a great presentation. And thanks, Yvonne. You're amazing too.
Thank you. Thanks, everybody.
Thank you so much, everybody.
See you at the next webinar.
November. Yes.
November.
See you then.
Bye.
Thank you. Bye.